Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan, and my mission is to make psychology accessible to all. In today's video, we're going to talk about autism spectrum disorders. We're going to start with a brief history of the condition, and then we'll go into some of the diagnostic criteria, some of the common symptomology of autism spectrum disorders. We'll talk about some of the neurodiversity related to individuals on the autism spectrum, as well as some of the prevalence factors linked to the condition. So without further ado, let's get into it. When we discuss the history of autism spectrum disorder, it is a fairly complex neurodevelopmental disorder which is characterized by persistent differences in social communication and social interaction across multiple contexts. Now, the DSM-5 diagnosis characterized by struggles with social interaction, struggles with communication skills, and highly intense and repetitive patterns of interests and behaviors. So you might hear the term perseveration or perseveration of the sameness, which means that they like things in a specific way. And any change could disrupt the emotional state of an individual on the autism spectrum. So Leo Kanner described this concept of perseveration of the sameness, and he coined the term autism itself. So the word autism, the root is auto, which literally means within oneself to describe these children. And then Dr. Asperger characterized what has been known as Asperger's disorder. Now, Asperger's disorder has been absorbed into the autism spectrum disorder family as one of the spectrum-based conditions. And we see that autistic children behave in quite diverse ways relative to non-autistic children. For example, the individuals on the autism spectrum might spend a long amount of time doing repetitive motor activities. In full disclosure, my son is on the autism spectrum. And when he was quite young, he would spend hours lining up Matchbox cars over and over and over, which became his personal freeway, right? So our living room, you would see hundreds of cars, and he could do that for hours. In addition, he would notice if something was out of place. So you see this kind of hyper focus on these repetitive activities. You also see focus on the minutia or the small details in the world rather than the larger environment. And I'm going to show you an example of that on a slide that follows. So when we talk about deficits in social communication, social interaction, that comes in the form of both linguistic challenges, because about half of individuals on the autism spectrum are nonverbal, and the other half might struggle with social relationships. We talked about the repetitive pattern of behavior, interests, and activities. A person might want the same food over and over and over. There is some level of distress when we look at the diagnosis. There has to be some level of impairment related to social, occupational functioning, linguistic functioning, educational functioning, etc. And these symptoms show up pretty early, and you can detect autism spectrum disorders in an extreme case, actually in infancy. And we'll talk about the American Academy of Pediatrics and their guidelines for screening for autism spectrum disorders. Now, when we're diagnosing autism spectrum disorders, the disturbances that we talked about, the social communication, the repetitive patterns of behavior, the impairment has to be due to autism and not better explained by some global developmental delay or an intellectual disability. So when we talk about ASD, or autism spectrum disorder, uh, there is a spectrum. And you might say, well, why is autism on a spectrum? The answer is because there is a broad range of symptoms, abilities, and characteristics from individual to individual. So if you have 10 individuals who are on the autism spectrum, their combination of symptoms will look quite different. So you have to have a very individualized approach to treatment. So, as I said, not only do they differ on their presentation, but they also may display features not specific to autism spectrum disorder. We see co-occurrences or comorbidities of obsessive compulsive disorder, and so forth. Now, there are factors that influence the spectrum. So, level of intellectual ability plays a role in where a person is on the autism spectrum. Differences in language, whether a person is fully verbal, has some verbal ability, or is nonverbal, that's going to affect the presentation of a person on the autism spectrum. And the manifestation of autism changes with age, and that's very important for us to understand. My son moved out of his car phase and then became very rigid about his food, and then became very rigid about his play patterns. And then it was the need to have every Power Ranger, and any change in schedule would set him off. So there were these behavioral changes that we see with age. So when you develop an individualized treatment plan, you have to be mindful that the symptomology can shift with age. So let's talk about some of the social interaction and communication differences. We said earlier that one of the features of autism is that autistic children have differences in socially oriented behavior, regardless of cognitive ability. So, examples of social interaction communication differences include a preference to focus on one's own activity. So, we see that if there is a choice between joint attention and focusing on something together, doing one's own thing, uh, autistic children tend to prefer their own activity. We also see reduced levels of eye contact, which is part of the rules of social communication. We also see a preference towards neutral facial expressions, and preference for parallel play. Now, parallel play is if you see children, I don't know, at preschool, they could play together or they could play side by side. When we talk about parallel play, there is a preference for playing side by side, but not necessarily with one another. So these are just examples of social and communication differences. So we typically see that one of the signs of autism spectrum disorder, which is pretty early, is the inconsistent use of pre-verbal communications. And the statistics have shifted a bit to about 30 to 40% of individuals on the autism spectrum never develop useful language. And there is more of a proto-imperative gesture. So that might be pointing, as in saying, give me, versus a proto-declarative gesture, right? So things like showing or joint expression, there is a reduction in ability. We also see that individuals on the autism spectrum struggle with pragmatic language. And pragmatic language are the unwritten rules of language. So things like sarcasm, things like emphasis and how emphasis impacts a sentence. These cues are going to be missed, even in individuals who are what we call higher functioning. So to look at some of the expressive and instrumental gestures, autistic children with no speech or limited speech use instrumental gestures. And that's how they get someone else to do something for them. So it might be putting their hand up to say stop, or it could be tugging on an arm for someone to open up a food box and so forth. These are instrumental gestures, whereas expressive gestures are used to convey emotions or feelings. So you'll see a reduction in expression of sadness and embarrassment with individuals on the autism spectrum. Now, we talked about repetitive behavior and interests. So we do see individuals on an autism spectrum tend to have higher frequency, repetition, and a preference for the sameness in their environment. One of the things that is important is to have structure in one's day. And if you're going to deviate from a structure or a pattern, you must build in transitions so the child can adapt to that. We also see repetitive speech. So echolalia is where a child might repeat what is said to them instead of reacting in a fluid manner. So if I were to ask a child, how are you doing? Instead of answering how they're doing, they might repeat back as an echo, how are you doing? Right? So instead of answering how they're doing. And perseverative speech is where a person may get hooked on a topic and they can't break free from it. So they're repeating over and over the same thing. Now, we see stereotyped or repetitive behavior, whether it is sensory or motor activities, we see stereotyped behavior. So one of the co-occurring diagnoses is OCD due to this ritualistic or patternistic behavior. We also see self-stimulatory behavior. Self-stimulatory behavior can be any of the senses. So it could be reflecting light onto the eye. It could be rocking back and forth. It could be tapping and so forth. These are self-stimulatory behaviors. Now, there is a form of self-stimulatory behavior that is concerning, which we call self-injurious or self-abusing behavior. And that pattern is one of the early foci of treatment. So another thing we see is that there are differences in intelligence, and a diagnosis of an intellectual developmental disorder is fairly common. Now, we said that when diagnosing a child with autism, we have to be careful that it's not better explained by an intellectual disability. That doesn't mean that you couldn't have both diagnoses. And we see as many of 25% of autistic children show some level of above average intelligence. And we also see about 5% having some kind of splinter skill, or you might hear it referred to as a savant ability. We see differences in cognition and motivational factors. So there might be differences in interpreting a situation that requires some social understanding. It's not uncommon for a person on the autism spectrum to state something as if it were true and misinterpret the whole experience. There is limited pretend play. There's limited desire to engage in pretend play. Now, when we're picking up language between the ages of maybe 2 to 6, we engage in pretend play and practice social scripts. So the fact that individuals on the autism spectrum don't engage in pretend play, that's pretty significant. We also see difficulties with theory of mind. And when we talk about theory of mind, that's the ability to understand another person's point of view or their mental state. Well, individuals on the autism spectrum struggle with that. Okay, so there are other general differences, such as differences in higher order planning and regulatory behavior. So we might see challenges with executive functioning, impulse control, self regulation, and so forth. We also see difficulty with central coherence, which is central coherence is the ability to interpret the composite image or a global way. And instead of interpreting globally, there might be a hyper focus on one aspect of that image. So here's an example of that, where if I were to ask you what the pictures are, the top picture, it's very easy to say, oh, that's a bike. And then on the bottom picture, it's a boat. Well, it's easy for us to see that global image, but an individual in the autism spectrum might focus on the hidden tent on the bike, which if you look at the back wheel, there's a triangle. Or an individual on the autism spectrum would focus on the cabin of the boat and view it as a hidden house figure. So you can see that there is limited focus on central coherence and hyper focus on some smaller part of his stimulus. So we talked about difficulties in theory of mind. Again, theory of mind is the ability to put yourself in another person's point of view and understand their thoughts and emotions. We also see the deficits in executive functioning. Now, it varies, and it's on a spectrum, all of these, right? But we don't have a single cognitive abnormality that explains all deficits. And that's an important thing as well. So what are some features that manifest alongside autism spectrum disorder? If we talk about medical conditions, 1 out of every 10 children on the autism spectrum have some coexisting medical condition. And a common one is sleep difficulties, and nearly 1 out of every 2 children on the autism spectrum struggle with sleep. We also see about half of children on the autism spectrum have some GI issues or digestive issues. Common report of physical appearance or facial appearance is to that individuals on the autism spectrum tend to have typical or attractive physical appearances, but there is a tendency to have a larger head size relative to the normal person. We also see other diagnoses, mental health diagnoses. Over 90% of individuals on the autism spectrum have a co-occurring mental diagnosis. And common mental diagnoses are intellectual disability, epilepsy, anxiety, ADHD, learning difficulties, oppositional defiant and conduct disorder, and mood disturbances. And we see about half of children on the autism spectrum have about 4 or more diagnoses. So there are significant issues related to co-occurring disorders. We also see self-injurious behavior, which I talked to you about, which is extreme and persistent and sometimes life-threatening. Now, a self-injurious behavior can be banging one's head against the wall or against the crib, or biting one's arm, or running into the wall. Any number of these things are examples of self-injurious behavior. So what's the prevalence? Now, in the DSM-4, it used to be said that there was roughly 1 in 2,000 children diagnosed with autism. Now, the DSM-4 originally was released in the 1990s, and then there was a text revision in the early 2000s. but it has grown. And we see currently it's about 1 out of every 36 children have a diagnosis of autism spectrum disorder. And you might ask yourself, well, what's going on with that? And there are several answers as to why the prevalence has increased markedly. One of the answers is we have better early detection and diagnosis and screening factors. The other answer is that there are 5 conditions that were absorbed into the autism spectrum disorder. So between better diagnostic ability and a broader category or spectrum of conditions, that explains the sharp increase. Now, this is a 4, sometimes 5 to 1 times more common in boys relative to girls. So there's approximately 4% of boys, 1% of girls. It differs internationally, but it is found worldwide. We do see that race and ethnicity does not play a role in core symptoms of autism spectrum disorders or the likelihood of being diagnosed. Now, how societies integrate autism spectrum disorder into their cultural framework, that does differ from culture to culture. So what's the age of onset? Well, I said you can detect autism as early as infancy. So anywhere between 12 to 18 months seems to be the earliest point where you can diagnose autism spectrum disorder reliably. Now, it should not shock you then that the American Academy of Pediatrics recommends a screening at 18 months and 2 years. Well, why would you be able to detect it as early as 12 months or 18 months? It's simple. The linguistic delays, the language delays, the social relation delays are so extreme that it's easy to detect. Now, the good news is early detection leads to early intervention. And the earlier you get treatment for autism, the better the outcomes. So that's the good news about early detection. And we see that children with autism spectrum disorder have a whole host of different outcomes. So individuals on the autism spectrum, they're likely to struggle with features of autism for the rest of their life. And the symptoms become more challenging in adolescence. You might see hypersexualized behavior in adolescence, which is a real challenge for individuals on autism spectrum and working with individuals. We also see more complex patterns of obsessive compulsive rituals that persist into adulthood. Now, when we talk about problems in early development as a factor, well, we know that prenatal development, everything is happening, right? So if you experience prenatal problems or exposure to teratogens, which are these harmful environmental agents, you're more likely to be diagnosed with ASD, right? So it's interesting, right? So we have these prenatal risk factors and neonatal to some degree. We also know that there are genetic abnormalities or anomalies, and individuals on the autism spectrum have a 5% risk of chromosomal abnormalities. So genetic testing is an important part of working with individuals on the autism spectrum, and 1 in 4 children with tuberous sclerosis have autism spectrum disorder. So when we talk about other factors like family-related factors, twin-related factors, and so forth, we know 15 to 20% of siblings of individuals on the autism spectrum disorder have the disorder. So we call this an autism phenotype, an outward expression. Now, in twin studies, identical twins, the rates are about 70 to 90%. Now, keep in mind, if we said it's about roughly 1 in 40, the general population has a little over a 2.5% chance of being diagnosed with autism, but with siblings, it's a 15 to 20%. And with identical twins, it's 70 to 90. So there is a genetic part. And we see with molecular genetics that there are areas on different chromosomes that create susceptibility for autism spectrum disorder, right? Now, the genes themselves can also be influenced by environmental factors. We talk about epigenesis, so the environment can turn genes on or off, and there is no localized brain difference in terms of autism spectrum disorder. We will talk about different regions looking different, but it's not a localized difference. So we do see the wiring or connectivity across the brain networks as being more of a likely explanation for what's going on with autism spectrum. Now, other genetic or biological factors, we see cerebral gray and white matter overgrowth. That is a excessive amount of structural abnormalities. We see decreased blood flow to the frontal lobe, which is for executive functioning, and the temporal lobe, which is for emotion-based processing and auditory linguistic processing. We also see there are other risk factors. So early risk for autism spectrum disorder leads to other challenges in later development. So we have to be mindful that autism spectrum disorder is going to alter how the child adapts to their environment. So you might have children receiving what's called COMHAV, which is basically rehabilitation in the community, teaching social skills, teaching how to order off a menu, teaching how to wait in line, things like that. These are later challenges that we try and target, and we'll see different developmental patterns. So that is a very quick depiction of autism spectrum disorder. In our next video, we're going to talk about treatments of autism spectrum disorder, and not to give it all away, but there is a broad range of treatment interventions. I think there was something like 400 distinct treatment modalities that are evidence-based, but I'll leave that for the next video. If you found this video meaningful, please hit the like button, subscribe, consider clicking the notifications tab so that you'll get an alert when I release my next video. Lastly, I ask if you have a thought or a reaction to the video, please feel free to put it in the comment section below, and I read and respond to all comments I get. So I look forward to your comments and your reaction to the video. But until next time, take care, everybody.